good afternoon, everyone. This is Christy Wergeen with the Lake Superior Quality Innovation Network. I would like to welcome you to Fighting for Dignity, Prevention of Resident-to-Resident Negative Interactions in Dementia in Long-Term Care Homes. This webinar is intended for providers working with quality innovation networks in Alaska, Colorado, Hawaii, Illinois, Iowa, Kansas, Michigan, Minnesota, Montana, Nebraska, Nevada, New Mexico, North Dakota, Oregon, South Dakota, Utah, Wisconsin, and Wyoming. All lines will be muted during this webinar. At the end of the webinar, there will be a short time for questions, but you may also ask questions in chat. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speaker has reported no conflicts of interest, and there are no planner conflicts of interest. For CE credits or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive during the presentation. We encourage everyone to complete the evaluation to provide feedback on the session. Our featured guest speaker is Dr. Elan Caspi. Dr. Caspi is a gerontologist and dementia behavior specialist with Dementia Behavior Consulting, LLC. He has worked in the aging field for 22 years, starting as a nurse aide in a nursing home where his grandfather lived. Since then, Elan has worked as a social worker in a nursing home, consultant, educator, knowledge broker, author, and advocate. In the last 12 years, he has focused on developing ways to improve the quality of care and life of people with dementia. I will now turn the presentation over to Dr. Caspi.
Thank you, Christy, for this nice introduction, and thanks for inviting me for this presentation. Also, Kathy here, and Jenna helped us with the technical aspects of this presentation, as well as Catherine, who helped earlier with the presentation. So today we're going to talk about a prevalent, concerning, but under-recognized public health problem. And you saw the title of the presentation a minute ago. I'm just going to mention a couple of housekeeping things, kind of a general, and then we're going to start the presentation. The first thing is that the presentation is based on a extensive review of the practice and research literature, as well as based on a 10-month direct observation study that I conducted in 2 care homes for people with dementia, as well as my work as a nurse aide, social worker, and consultant in long-term care homes. Today I will focus mostly on verbal and physical manifestations of this behavioral phenomena. I will not focus on sexual negative interactions, even though they are as important, but it's beyond the scope of the presentation today. We can relate to it during the Q&A if you'll be interested. On the last slide, you can find my contact information. You're welcome to email me later on and ask questions or share any comments or thoughts or resources you have about this public health problem. You also find a link to my website as well as a blog that is dedicated to this problem. All right. So, as many of you who work with people with dementia know that some of the most compassionate acts occur between people with dementia. Unfortunately, the flip side of it also occurs, which is the topic of this presentation. As we saw in the previous slide, thank you. Dwayne Waltz was an elder, a Korean War veteran, and one evening after 9 p.m., he walked into another resident's bedroom and climbed into his bed. Minutes later, another resident with dementia walked in, saw him in his bed, and beat him repeatedly with his cane. Dwayne was severely injured, and he died a week later. All right. So this is clearly a serious problem, and I'm going to review a series of fatal incidents later on. So what are the objectives of this presentation? I'm going to talk about some of the consequences of these behaviors, some of the contributing factors, causes, and triggers, as well as some strategies for prevention and de-escalation. And the focus is on psychosocial and environmental strategies. So those of you who work with people with dementia in long-term care homes know that this behavioral phenomena is not new. In fact, it goes back decades. I recently was able to find a record indicating that the first woman to be diagnosed, the first person to be diagnosed with Alzheimer's disease, Augusta Deter, was a target of these behaviors. So nothing new. This is a definition, one definition from the Cornell group, who conducted the largest number of studies on these behavioral expressions. And they defined resident-to-resident aggression, or what they use, resident-to-resident elder mistreatment, as negative, aggressive, and intrusive verbal, physical, material, and sexual interactions between residents that in the community setting would likely be unwelcome and potentially cause physical or psychological distress or harm in the recipient. And I underlined the word community because, as Professor Mark Locke said, if someone would walk into my office one day and tell me, Mark, blank you, he said, I would probably need to lie down for 2 hours, let alone if someone would lay a hand on me. But for some reason, there's normalization of these behaviors in long-term care homes. And I believe that, and others also believe that ageism plays into it, and misconceptions about people with dementia. Even sexism plays into that. So you have to trust me here that these behaviors are very common, there's high prevalence and incidence, and it was shown in 2 large-scale studies, as well as a literature review, a recent literature review, and you see the information here, but I rather focus more on other parts of the presentation. You can always revisit it, and I can share more information about it later. But unfortunately, the majority of these behaviors are never reported, neither internally or externally, in many nursing homes and assisted living residences and adult day health centers. And it's not only the underreporting, but it's also the poor quality of reporting, and we're going to talk about it later. And these issues represent barriers for prevention. Another major gap is that the MDS 3.0, to my knowledge, behavioral E-section does not enable to identify the target of these behaviors, whether it's towards staff or residents. And why is it a major gap in practice and research? Because if we would have one variable that enables you to make this distinction, we can link it to the entire MDS and other data sets to shed light on some of the protective factors and risk factors of this problem. Now, behavioral expressions that are often labeled as aggressive or violent in people with dementia are mostly expressions of unmet human needs. They have meaning, purpose, and function to the person, even if they can't articulate it. They are attempts at communication that we need to explore with validation, as Judith Berry tells us. And they are attempts at gaining control over unwanted, threatening, or frustrating situations. And an attempt at preserving one's identity, personhood, and dignity. And in a way, they can be helpful in the sense that they can be barometers for the resident's tolerance to stressful stimuli. So, the late Professor Tom Kitwood, who wrote the groundbreaking book, which you see the title at the bottom of the slide, conducted years of observations of people with dementia, and he identified 6 main psychological needs that, in fact, all of us share without being old or having a dementia. So the need for psychological comfort, the need to preserve one's identity and personhood, the need to be occupied in something meaningful and purposeful, to be included with a group one feels comfortable and enjoys being with. The need the attachment is the need to be in relationships with other close relationships and trusting relationships. And the central need we all share to love and to be loved by others. But unfortunately, in many long-term care homes, when we don't pay enough attention to these psychological needs proactively on an individual basis, this is considered a major contributing factor to these behavioral expressions. So we know that by far the single most important asset we can have with people with dementia when we work with them, interact with them, is close trusting relationship. In fact, some of the best organizations out there, they put it on their mission statement, and that this is the number one thing they're trying to do, to build and maintain close relationships with the residents. When we're successful in doing it, we're in a much better position to understand and prevent these behaviors, and when we are not successful, then we should expect there's 20 reasons why. There's a link at the bottom. But just to mention a few, to have a meaningful conversation with a person, to plan the physical environment that is familiar to the person, to plan activities that are tailored to the preferences and abilities of the person, and to also identify triggers that are immediate or remote triggers from the distant past. So picture a beautiful sunny spring day, and a group of veterans are transplanting blooming tulips, and everything goes well. Suddenly, one of the veterans becomes hyperventilates, he becomes anxious, and he pushes another veteran. So they take him to the locked unit, and then after he settles down a little bit and was calmer, they tried to figure out what happened, and he said that he became distressed on seeing the tulips. So they reviewed his life history, and they found that several decades ago, several of his platoon were cornered in a tulip field, and they died there. So we need to be aware of those triggers, and we need to work with families to identify what could be triggers from the distant past. Things can travel 60 years, and then often they're unfortunately being taken out of context in the here and now. So consequences of resident-to-resident negative interactions could be anywhere between mild and serious. Because of in the interest of time, I would focus only on the target resident in terms of the consequences, but there's several other groups of people that are impacted by these behaviors, as well as the long-term care home, the society at large, and there's also substantial cost implications when we think about expensive psychotropic medication, hospitalizations, property damage, staff turnover, etc., etc. So, consequences for the target resident. You can see here, I'm not going to go through all these examples. You can see here the divided between psychological impact on the target resident, physical impact, a lot of injuries, fractures and brain injuries, and then there's also dozens of reports of death in the media. And I underlined the word false because one study in Canada in 3 long-term care homes with about 130 residents used a video-based, study in the public spaces of the unit, found that 9% of the falls took place during this specific type of episodes. And that's actually a very large number if we know how many falls occur in nursing homes in general. And many times we say, oh, she had dementia, she was unstable, what do you expect, she just fell, when in fact somebody may have pushed her, or it was during an episode of this nature. And so I have a blog, and you can see the last slide, but over the years, and I'm following this phenomenon in the last 8 years, I learned more about injuries and death subsequent to injuries, and I started to feel that there's many deaths reported in the media. So I decided to review the circumstances surrounding them, and I identified 40 deaths due to resident-to-resident altercations in the context of dementia. And by that I mean at least one of the residents had dementia, whether it's the exhibitor, for lack of a better word, or the target, or both had dementia. And we're going to see some of the key findings in the next slide, but since then, since the publication of this editorial, I identified another 10 fatal incidents in the context of dementia, and 20 others I already found before the publication where there was no indication of dementia in the episodes, but there were fatalities, another 20. So now we're talking about 70, and there's probably much more that we don't even know that take place. So some of the key findings, and I have to emphasize that this is not a research study by any means. It's more a call for research. Because we know the inherent limitations of newspaper articles. But still, I'm not aware of a database beyond coroner databases or related ones that you can conduct analysis. In fact, there's a group in Australia that actually responded to the editorial, and they're conducting an analysis of coroner reports of death due to these behaviors. So we're looking forward to see what's going to come out of this, what kind of clinical insights can come out of this report, the report. So in terms of the nature of the physical contact, about 1/3, one resident pushed or beat another resident, and it caused a fall. On average, between the incident and the death of the resident took 8 days, but 1/3 of the residents, the target residents, died on the same day. Over 2/3 of the incident took place inside bedroom. during the late evening hours, I should emphasize. And as well as over 60% took place during weekends. Now, we all know what should happen during evening hours and what should happen during weekends, but doesn't always happen in terms of programming, in terms of supervision, staffing, and experiential learning, in terms of guidance of managers, of directors, staff. So these are clearly vulnerability areas that need to be addressed proactively. And the majority of the incidents were not witnessed by staff. And you can see a link to the editorial. You can review it later at another time. So moving on to some of the contributing factors, causes, and triggers. So there's at least 5 levels of these, but in the interest of time, I'm going to focus on the last 3 that are noted on the slide. The physical environment, situational causes and triggers, and care partners and organizational factors. You can see the first 2 levels, there's very important, as important, resident history and background factors, as well as physiological, medical, functional causes, and specific types of dementia, as well as serious mental illness, which plays a significant role in these behaviors. So, I'm going to relate here to some of the factors in the physical environment. So, in recent years, the whole idea of congregating a large number of people with dementia on a care unit has been called into question, such as by Dr. Alan Power. And I think this needs to be re-examined. It is probably no surprise that at least 2 or 3 studies show that this type of behavior occur 2 or 3 times more than in traditional care homes. That being said, you can have a care home for people with dementia that provides excellent care and lower level of these behaviors. But I really think that we need to reconsider and re-examine some of the basics that were just keep building the same, and there's more and more special care units, but we need to kind of revisit the idea in a serious way because it makes an impact on these individuals. Another factor is large units, and as well as a floor plan or layout that limits staff ability to supervise residents effectively. And then we have inadequate landmarks and signage that exacerbate already wayfinding difficulties in many people with dementia. So the next thing that happens, they walk into another resident's bedroom and an altercation occurs. Crowdedness, too many people in a small space, they become overwhelmed and react negatively. Noisy, overstimulating, or hectic environment. One study was called the Quiet Week study. They decided no overhead paging, no loud greeting and goodbye during shift change, no radio, no TV. They reduced behaviors that were classified before as aggressive substantially during that week. And then we have lack of privacy or private away spaces. We all want to have, it's a human right to have a private space to decompress. And here I'm talking about spaces beyond the bedroom. But unfortunately, many nursing homes were built after hospital model, and they were not designed to provide these spaces. And then we have private versus shared bedrooms. The standard today should be private bedrooms. This is the last frontier of privacy that these individuals have, and this is their home. So we have many conflicts between roommates. That being said, there will always be elders with or without dementia that would prefer to have a companion, but that needs to be monitored, assigned carefully and monitored carefully. Indoor confinement, again, it's a human right to be outdoors, at least half an hour a day when the weather permits, in a secured outdoor garden, for example, with adequate staffing. Hallways are too narrow, and residents become impatient when residents in front of them walk slowly, walkers bumping into each other, wheelchairs, and before you know it, a resident strikes another or pushes another. Dead ends at the end of the hallways, residents unable to retrace their steps, and several residents congregate at the end of the hallway, and an altercation develops. Inadequate lighting and glare, we know that glare contributes to these behaviors, and inadequate lighting and quality of lighting causes misperceptions in these individuals. Feeling too cold or too hot, thermal discomfort, lowers the resident's threshold of other residents' behaviors. TV can be a major source of anxiety, and these interactions for a subgroup of residents with dementia. All you need to do is to open the TV, the evening news, and see bridge collapse, fires, terror attacks, wars, and some people with dementia are unable to differentiate what's happening inside the TV and what's happening in the room, and they're reacting to it. Elevators, another place where frequent altercations occur. In fact, one VA medical center decided to eliminate the need of residents to use elevators, and they reduced altercations by 50%. And access to sharp and dangerous objects. Over the years, I was shocked to learn about the objects that are used by residents during this episode against other residents. And they're thinking really non-traditionally and creatively, and so should we. I'm going to relate to it a little bit later. Moving on to situational causes and triggers. The first thing I think we need to consider is the fact that most people, elders or people with dementia, especially, never chose to live in long-term care homes, in a nursing home in particular. So being institutionalized with all the things that come along with it, that Dr. Irving Goffman wrote in the 60s with his book, Asylums and Total Institutions, are really kind of operating in the background, so we always have to remember that and accommodate for that. Boredom is a frequent cause of these behaviors. I did close to 2,000 hours of observation. It was pretty obvious that it's contributing to these behaviors. And many times when you look closely, what you see is situational frustration, interpersonal stressors, and sometimes it's just simple misunderstandings, but we have staff that are understaffed and overworked, and they may not be in every place to observe these behaviors and respond immediately. Invasion of personal space is a frequent trigger. There's a lot of problems with sitting arrangement, intolerance of other resident behavior, repetitive questions, unwanted touching in the dining room and during activities, taking in other belongings, and then, as I mentioned earlier, entering another resident's bedroom is a frequent trigger of these behaviors. And then conflicts between roommates about rules for using the bedroom. And here we talk about whether the disagreements about whether the window should be open or closed, the door should be open or closed, the light should be on or off, the radio or the volume of the TV should be too high or not. And in one incident, two residents were fighting over a dividing curtain. It ended up with an injury and death of one of the residents. One wanted it open, another wanted it closed. Racial and ethnic comments and slurs, this could be a trigger, but it can also come later during the episode itself. And then one of the most overlooked areas is people who are LGBT, and there's already indications of discrimination or hostility towards these individuals that plays into these behaviors as well. And when we look closely, most of these triggers actually represent unmet human needs, which implies that they are potentially preventable. Now, one of the other first things we need to ask ourselves, honestly, is where on the spectrum of culture change our organization is at. Whether we're on the biomedical side, or are we really committed in implementing person-directed practices and anywhere in between. Some long-term care homes say that they're ready, but they're not really ready. They're not really committed. They don't understand what goes into it. So in Connecticut, for example, there is a project, it's called the Dialogue Project, and it's offered by the Alzheimer's Research Center of Connecticut, which is an innovative center, and they are based on Dr. Ellen Power program, when they take staff for 1 year and take them on retreats and doing a lot of training, intensive trainings, to really support culture change processes. So the next factor is really inhumane staffing levels and very high stressful working conditions. This is not only cruel for residents, but also cruel for direct care staff. And I don't know when in the history of the development of nursing home we allow 1 to 10, 1 to 12, 1 to 15, 1 to 20 ratios in nursing homes. How would we feel if our babies or toddlers would be cared within these staff resident ratios, staff baby ratios, or staff toddler ratios? In fact, one international study compared 3 provinces in Canada to 4 Nordic European countries, and they looked at what they classified as violence between residents and staff. And they found that in the 3 provinces in Canada, there were 7 times higher levels of violence towards staff. And one of the major contributing factors that accounted for the difference was staffing levels that are much better in general in northern European countries. How many times are we going to talk about understaffing in the context of elder abuse and neglect? How many times are we going to talk about it in this context? So then we have lack of training in prevention of these behaviors, not only in the context of people with dementia, but also people with serious mental illness. And then we have a lot of people who shouldn't work a single moment with older adults in general, not to mention with people with dementia. So the screening and the hiring process should be very strict, and the standards should be high as much as possible. And then we need to make sure that managers provide support, guidance, supervision to staff, especially during evening hours and weekends. Many times we see tense and dysfunctional relationships between employees, and this is not only within departments, but also across departments. And who pays the price? There's a hierarchy of organizational structures. I served in the Army, and sometimes it feels like in the Army when a manager works in, and what we really need, and when the manager walks in and there's kind of a command approach or a blaming approach, and instead of what we need is to put the residents and the direct care staff at the top of the organizational chart, like Jane Claremont is doing here in Minnesota and others, but not only on the organizational chart, but actually to be committed to perceive direct care staff as the most important employees in the organization, and everybody else serves them to enable them to provide best care for the residents. Staff burnout could be a cause, contributing factor, but also an outcome of these behaviors. And then we have inappropriate approaches, attitudes, and communication style by staff members, and we have an Elder Speak line of research that demonstrated effects on behaviors, as well as Tom Kitwood's malignant social psychology, which are certain approaches and attitudes of staff that we need to work and educate to improve, because they're contributing and escalating these behaviors. And then we have inattentiveness to early warning signs of distress and frustration, and lack of cultural mismatch between staff and residents, but also between residents. Moving on to prevention and de-escalation strategies. This is really the heart of the presentation, so we're just going to dive right in. So we all want a magic bullet and a quick fix, but the reality is that these are, we usually talk about cumulative effects of multiple factors that operate at multiple levels of the organization and beyond, that intersect with the residents' cognitive impairments and lead to these behaviors. What we really need to understand that we need a deep, endless culture change journey and commitment to it, and fundamental changes in practices and organizational operations, and strong and ongoing commitment from all, if we want to have a lasting effect on these behaviors. So there's these 5 levels of where prevention can take place. In the interest of time, I'm going to focus only on the last one, but there's also strategies beyond the organization, outside the organization, that are as important. I did include them in the slide, but I just wanted you to have it, but I'm going to skip them let's see, and move directly towards strategies at the organization level. And I'm sure that most of you are familiar with these issues, but just to mention in brief, resident-to-resident distressing and potentially harmful interactions need to be explicitly acknowledged in the policy of procedures, as well as the measures taken to address them, the resources allocated to address them, reporting procedures, etc., in the policies and procedures. Every long-term care home should have realistic admission criteria and really avoid admitting residents that your staff members are incapable or untrained to care for them effectively. We need to conduct pre-admission behavioral assessment that is comprehensive, which informs the decision of whether to admit the resident, but also if we decide to admit them, it should inform proactive, anticipatory, individualized care plan for these individuals. Because there are studies that show that many of these behaviors occur during the first 3 months after admission. Again, we want to employ the right people and train and support them well. That's absolutely critical. We want to use consistent assignment, also called dedicated assignment, in order to strengthen and nurture those close trusting relationships we talked about earlier. We want to develop a roommate selection and a reassignment policy for those long-term care homes that haven't moved yet to private rooms. We want to strengthen a reporting policy. We really need to shift from the chronic culture of blaming the care staff, to a culture of learning. So for over 200 days, I reviewed communication log by staff. First of all, I rarely saw a positive indication of something that works, number one. And second of all, are we using the communication log, the daily communication log, as a learning resource, or are we using it as a labeling resource? We want to improve quality of documentation. It's not enough to say Mr. Smith hit Miss Allen this afternoon. We have to really try to capture the circumstances and sequence of events and triggers that led to the aggressive act, because this is the real window of opportunity for prevention. We want to develop and implement policy to avoid wrongful evictions, as well as to hold resident council and family council meetings. Residents in early stage dementia, when the conditions are created, are perfectly capable of representing their voice and their opinions, as well as those who are further along in the disease process. Moving. Thank you. Professor Cohen-Mansfield, who conducted the largest number of studies on behavioral expressions in this population since the late 80s, tells us that the most important principle in addressing these behaviors is to understand the meaning of the sequence that led to the aggressive behavior. Now, there's a few encouraging findings in the research. One is that early warning signs and situational triggers can be observed in the majority of these episodes. And by early warning signs, I mean something in the body language, facial expressions, tone of voice, gestures, and is signaling that something is about to happen. And we need to train staff to identify those early warning signs. The other thing is that those behaviors tend to occur in patterns. By patterns, I mean by time of day, location, events, people, and objects, both at the individual resident level and at the group level. And another encouraging finding is that it's usually a small number of residents that account for a large portion of these episodes. And we know that most long-term care homes are constrained with their budget for resource allocation to address these behaviors. But we really have a small group that we can target efficiently our resources to prevent these behaviors with these individuals. By the way, several other studies show that the same finding is that it's true in psychiatric hospitals with people with serious mental illness. So Judy Berry, who is the president of Dementia Specialist Consulting here in Minnesota, tells us that the best way to handle these behaviors is to prevent them from occurring in the first place. And Jan Gerard from the Minnesota Department of Human Health Services here in Minnesota agrees with Judy Berry and adds that unfortunately we spend too much time responding reacting to the behavior when we should react and address attentively, proactively the cause. In one care home for people with dementia, there were frequent incidents between residents. So they recruited and trained volunteers, and they led walking group activities immediately after dinner for 3 days. For 3 consecutive days, yes. And they compared it to 4 days without walking groups, and they reduced behaviors that were classified as aggressive by 30%. Proactive measures, we want to strengthen information transfer we really need to have structured mechanisms in place to improve communication between staff across shift days, weekends, holidays. Once a recreation staff walks in, after 30 minutes after an altercation between 2 residents, he's about to lead a group activity. He lets the same 2 residents to sit next to each other, start the activity, and of course they enter into a distressing and potentially harmful interaction. If that individual would read the communication log, or ask other staff members or become informed, he would make sure that these two individuals don't sit next to each other. So we need to ensure that everyone knows who are those residents without labeling are often involved in these episodes, including float staff, agency staff, etc. We really need to promote teamwork. It's absolutely necessary. We want to provide structured and consistent routine because we know that small changes are difficult and frustrating for these individuals, but we have to be flexible and use common sense. We want to instill empathy and compassion between residents. There's one champion held a helping hand group, and one of the goals of the group was to instill compassion between residents, and then they rewarded residents that actually went about doing it. And when we talk about training of direct care staff and interdisciplinary teams and managers, before training them on preventing these type of behaviors, we need to really establish the fundamentals. And there are two approaches here, habilitation therapy and validation method, that you can read more about in these links. And then we want to also have responsibility to protect direct care staff. And there's train-the-trainer courses that can enable you to train employees that they will then train your staff in protecting themselves in serious and dangerous situations. Next, please. Staff needs to be constantly alert. Of course, it's easy to suggest that when we're understaffed, it's difficult to do. And watch residents vigilantly. Things can happen in a split of a second. So again, identify and respond to early warning signs of distress and anxiety and frustration. And we need to really shift to proactive approach, to what is called anticipatory care approach. Professor Christine Kovacs, who coined this term, and to stop the vicious cycle of reactivity that is so common in nursing homes. We want to regularly move around the unit. The best team leaders walk around, they barely ever sit down. Yes, sometimes you need to do paperwork, but most of the time they're moving around because they're aware that things can happen anywhere at the care home, even inside a bedroom. We want to modify the physical environment and implement dementia-friendly guidelines. There's excellent resources and experts in this country. One of them is Steve Orfield with Orfield Labs here in Minneapolis. We're really conducting cutting-edge research and building nursing homes that are elder-friendly and dementia-friendly. It's really important to become aware of these guidelines and to consult with experts in the field. We want to remove and secure objects that use as weapons. Just to give examples, a hanger rod from the closet, a wheelchair footrest that was used to injure another resident, and then even a plastic bag that was used by one resident to strangle another resident. Ensure that the content on the TV is enriching, calming, and therapeutic. Ensure active presence of managers in the evening, weekends, and holidays, absolutely critical. We want to recruit volunteers and use them creatively. There's an example of that. We can share more later about it if you would be interested. And install emergency call buttons and use handheld radios. In this era, there's no excuse not to use technology. One recreation staff was leading a group activity. Two residents started an altercation. No other staff members were around. He had to leave the activity room, which you don't want to do with people with dementia at a certain point of the disease. Walked all the way to the care staff room, picked up the phone, called the front desk. All you need to do is to press a button or a pager to call for help. In fact, some of the best places require another staff member to stay right by the activity room or inside to help the group activity leader during the activity. We also want to use and develop assistive technologies such as visual dementia systems that enable to generate a signal in real time for staff when a resident leaves their own room or enters another resident's bedroom. We are working now on developing a technology with Steve Orfield that will enable to generate a signal at all parts of the unit, but this is a journey that will take time to develop it. Alright, so meaningful activities. These are individuals that live 60 to 90 years. They live active and productive lives, and they want to continue to feel useful, purposeful, and to have meaning in their lives. They want to have a reason to wake up in the morning, and they want to live a life worth living. We want to encourage creativity. Many times direct care staff come up with wonderful ideas, but they're either dismissed or ridiculed by managers. We really need to listen to direct care staff because they know the residents the best, they and the family members. So this is an example of a resident who was bored and he wanted to feel that he's working and he's useful. So Judy Berry creatively bought him a manual lawnmower. So he's now mowing the lawn outside and he's doing it in a safe way. And Judy said that it's the best $79 she ever spent. In the winter, they bought him a special shovel, which he's doing the same safely on the porch, which brings the same outcome. So activities are the main weapon against these behaviors. There's two experts here. The second one, Dr. Cameron Camp, says that the residents is engaged meaningfully, you can't simultaneously see behavioral expression. But of course, I'm adding at the bottom that if certain conditions are not met, you will see anxiety and behaviors. All right, but the reality is that most residents are not engaged in activities most of the time in most nursing homes. And there are several studies demonstrating that. Again, boredom can really be the enemy of a subgroup of residents with dementia. Others are perfectly fine sitting and greeting others and just being, and that's okay. The resident who is most at risk of engaging in an assaultive behavior towards another is usually bored, tells us an administrator of a nursing home. Again, two studies show that evening hours is a vulnerability time period, and a missed opportunity. We really need to provide activities that are suitable for the evening hours to engage these individuals. And one study 30 years ago showed that enhanced level of staffing in the evening reduced these behaviors. And Dr. Paul Rea from the Alzheimer's Association in Massachusetts said that a wise lawyer would first approach the activity director and ask, how did you engage the resident in a way that would have prevented the violence and injury against my client? And remember, the baby boomers who are seeing how their parents are cared for are really aging now, and they're going to have higher expectations of quality of care, and they're going to expected to use more lawyers. So we better be proactive about it and not just require one activity per day, such as in certain states and assisted living still required, which is outrageous. So immediate strategies during episodes. So Dr. Rea tells us that behavior cannot be directly changed, only indirectly by changing our approach or the physical environment. So Dr. Stephen Sorrell, who conducted training with thousands of daycare staff, tells us you want to engage in a swift, focused, decisive, coordinated intervention. We want to immediately diffuse the chain reactions because anxiety is contagious, and we want to redirect residents from the area and pay attention to this old lady who is shaking at the corner with dementia, who is paralyzed cognitively and can't remove herself from this situation or can't call for help. Also, residents who have poor judgment of safety, and they literally walk into the fire. One resident was hit by another. 4 minutes later, she goes to sit right next to the resident who was hitting her. So we need to provide the redirection in time. We want to offer to take a walk together, maybe in a secure, beautiful outdoor garden, and then, of course, to distract or divert to a different activity or change the activity altogether. The best activity leaders always have a plan B and C handy next to them. You don't want to leave the activity room, go to the storage area, and start to think what's going to be the next activity, because you're going to contribute to escalation of these behaviors. You want to refocus or switch the topic to a favorite conversation topic, but you need to know their life history to know what's their conversation topic. And then position or reposition and change seating arrangement, another major trigger of these behaviors. You want to physically and skillfully separate residents, and there's a resource and a DVD, recommended DVD later on, on how to do it skillfully. We want to avoid conversations in loud and crowded places. Some people with dementia really become upset and frustrated, and they will react negatively or just leave the area. I want to slow down. Never talk with people with dementia in the pace that I'm speaking with you now. One person with Alzheimer's said, she said, I am a slow motion version of my old self, not physically but mentally. Avoid approaching residents from behind or from the side because you know what's going to happen. They might strike you instinctively with their elbow, usually from the front. Establish eye contact unless it's threatening or culturally inappropriate. If the person starts to walk away from you, don't try to stop them immediately or grab their arm because you know what's going to happen, tells us Julie Berry. Maintain a safe distance from the person, slightly beyond striking range. Stick at the level of the eyes, never above the resident, towering them, because it can be threatening. You want to be at the level of the eyes because it sends a message of equals, it's non-threatening, and it's respectful. Stick with the residents, not at the residents. They can identify the difference. You want to try as much as possible. It's easy to suggest that. It's harder to do, to try to stay calm, because they will mirror your emotional state. There are studies that demonstrate that. They will respond to the unspoken, even if you said the right thing, tells us James Gerard. Be sincere. Many people with dementia can detect insincerity. Be firm and direct rather than angry or irritated. And again, identify the underlying need behind the behavior or words that may not make sense to you. Use short, simple, and familiar words and sentences in one step direction. Never ignore the emotions of residents. Encourage expressions of feelings, but do it in a safe way and location. Encourage a compromise between residents. And save face. This is very critical. Oftentimes what you see during a tense altercation is that the resident may say or do something that may be perceived as humiliating or embarrassing. You don't want it to fuel up and escalate the situation. Avoid arguing or reasoning or correcting or criticizing residents with dementia, because you can't win an argument with a person with dementia, and if you will, both of you will be miserable. Naomi Faz, the founder of validation method, tells us, validate the subjective truth, internal reality, and feelings of the person, no matter how illogical, chaotic, or paranoid it may seem to you. Of course, if it's safe to do so. Avoid using reality orientation in the mid to late stage of Alzheimer's. You want to use validation method in the mid to late stage of the disease. And avoid questions that challenge the short-term memory, such as, didn't I just tell you, or don't you remember? And absolutely critical is to listen to the feelings and less the facts. Respond to the emotions, not to the behavior. Turn negatives into positives. Instead of saying, no, or don't go there, or don't sit here, you can say, Ms. Smith, I prepared you a seat. Right here. Would you like to sit with me? And avoid using the word why. Why? Because many people with dementia at a certain part of the disease have lost the ability to have insight or to attribute meaning into their behavioral expression. Never command or demand. Instead, ask for their help. Many love to help and feel useful. Apologize sincerely when things go wrong. Ask the person for permission because it gives them a sense of control. It is usually non-intentional, so try as much as you can not to take it personally. Be patient and supportive. They're really facing an avalanche of losses. And Tipa Snow tells us, if what you're doing is not working, stop, back off, give the person some space and time, and decide what to do differently, and try again. But again, never leave residents with dementia alone when unsafe to do so. Seek assistance from coworkers, especially those you know the residents trust. Sometimes you see, it's amazing to see during a tense application that the residents will completely ignore one staff member, but will completely cooperate with another. Why? Because the second staff member took the time to build the trust during routine time. Be consistent in approach, because staff shifts days and weekends. We're really sending multiple messages to these individuals, and we really need to be unified in our approach. And promptly notify interdisciplinary team and physicians regarding episodes. This is the DVD that I mentioned earlier. Sometimes during an episode, when you try to de-escalate the situation, they may grab you, or try to strike or kick you, or pull your hair, and other situations. This DVD demonstrates beautifully how you can actually de-escalate it in a safe way, not only for you, but also to the residents. Because sometimes we try to de-escalate a situation, and the resident falls and sustains an injury. And then we have to pay attention. I want to be mindful of the time. I'm going to finish briefly, but mention that we really have to pay attention to what's happening after the episode. Not only these are reinforcers that shape future episodes, but we really need to provide this adult-to-adult reassurance to these individuals who we know have a difficulty to regulate emotions. We want to hold debriefing procedures and meetings with every person that witnessed it, but also every person that was there in the hour or two before. You want to seek emotional support from a trusted coworker or supervisor. Very important to decompress and process these emotions in a secure and discreet manner. You want to consult with a nurse or physician for first aid, evaluation of medical cause of injuries, and change in medication. You want to inform and consult with the family in a timely manner, in a reliable manner, and really value their input and insight. And reliably, because, for example, Judy Hand, the wife of Dwayne Walls, who we saw in the first opening slide, she was told on a Friday that he just fell, and she doesn't need to come to the nursing home. She came on Monday, and she was shocked to see his injuries. And then a staff member told her, "Oh, didn't they told you? He was bitten by another resident." Consider change in sitting arrangement, the bedroom and room assignment, and in a true emergency, potential for immediate harm, you want to consider transfer to a psychiatric hospital and neurobehavioral unit for evaluation. But we have to have realistic expectations for these settings. And when their report comes back, you want to make sure that the staff read the recommendations and implement them. So assessment is absolutely key, but we don't have time to address it. These are some of the characteristics of these. And these are some of the tools that you can use to address these behaviors, but we can address it later after the talk. This is an example of behavioral log, and a case example of how to use the behavioral log, and two recommendations to train all staff in addressing these behaviors, and these are some of the components of this training. And we really need to pass legislation and advocate to require humane staffing levels for residents and for staff. And Professor Carl Pillemar said, we talk about violence-free schools. Why we don't talk about violence-free nursing homes? What about ending violence in nursing homes as a policy goal? And I'm going to end here and open for questions and discussion. If you can just go to the next slide. And here you have, hopefully you can see a conceptual framework that you can use. The next one. And here is the first instrument to address these behaviors that was evaluated with over 2,000 residents in several nursing homes. So we can start using it in research and in practice. And you have my contact information, my website, and the blog with over 1,000 posts specifically dedicated to these behaviors. Maybe we can go back to the slide and the questions.
Sure. Well, I just want to say something brief.
Sure. Oh, sure.
Okay. Thank you very much, Dr. Cassidy. That was a lot of really great information. I know I learned a lot. I just want to remind everybody that part of the National Nursing Home Quality Care Collaborative that what Dr. Cassidy just talked about is very much relates to information in our change packages, strategy number 6, which is to provide exceptional, compassionate clinical care that treats the whole person. And please remember that in that change package, there's also an attachment called Avoidance of Unnecessary Antipsychotic Medications in Nursing Home Residents Living with Dementia. And you'll see many of the same things that Dr. Cassidy was talking about in the change package. So on this slide is information on how to access that if you haven't had an opportunity to look at it. So we now have some time for questions. We have a few in the chat that maybe we'll start with. And then we can go to the telephone line. So here's one from Mike. He says, how's the best way to address language barriers and cultural food differences between the residents and caregivers? For example, I support elderly Alaska Natives, and 97% of the staff in assisted living facilities are from the Philippines, American Samoa, or the West Indies. The staff cook food familiar to their country of origin and speak very limited English. So it sounds like maybe a communication barrier.
Well, I just want to see the question.
Yeah.
So is this, I wonder if this relates to differences between, traditions of food between staff and residents, or between also variation across residents. I'm not sure which one it relates to, but, the care needs to be person-directed, so we need to, as I mentioned earlier, need to learn about their life history and their preferences, and one of them is the preferences for food. So we want to have enough capacity to prepare food that is individualized, and then because the employees of the organizations, the director staff are the most important employees of the organization, we need to have capacity to also prepare food that is appropriate for them. Because the quality of care is only as good as the quality of support for staff. So, but we need to develop that capacity in terms of are they doing it in-house or with contracting with outdoor, with external vendors. So, yeah, it needs to be tailored. It needs to be tailored for staff, for residents and for staff.
Yeah.
Yep.
And then Catherine asked, how do you balance an emphasis on television that is calming with the more violent shows that a resident might prefer and family might support as dad's favorite show?
All right, so first of all, some residents are, as I mentioned earlier, are completely fine watching negative content on the TV, but then you have that subgroup that are impacted negatively. So, while this is their home, many times we talk about residents that live with 30 others or 40 others or 20 other people, and there got to be some need to be attentive and respectful to other residents' needs. So some residents can have a TV inside their room, but then we need to see the impact on a roommate, if they are roommates. But some places, I visited recently a VA medical center, a community living center, VA nursing home, and they actually decided to completely eliminate the TV from the main area because it impacted negatively so many residents, and they created a small space that is dedicated for those residents that feel comfortable watching the content on TV. But I almost want to hope that most residents are not interested to watch violent content on TV. But those who are, and if it doesn't impact them negatively, we can tailor it either inside their room or in a small space that is supervised by staff members.
Thank you. And here's another one. Oh, whoops. How do we, okay. All right. As operator, can you remind everyone how to get into queue in case anybody has any questions? And
yes, thank you.
Okay.
So, just a quick reminder, if you have a question, please press *1 on your touch-tone phone. And if you are using a speakerphone, please pick up the handset before pressing the numbers.
Okay, and while we're waiting for that, Dr. Caspi, here's another question. What do you do for staff that are facing caregivers burnout when caring for dementia elders?
So if I understand the question correctly, how do we deal with burnout? If that, I don't know if that's the question. There's many things you can do to support staff, from simply acknowledging their effort, being there during those tense times when they need the guidance, supervision, experiential training, and to create forums where they can decompress, share their frustrations. We want to, they meet in a discreet way. We want to reward them for their efforts. We want to have working conditions that are humane, from salaries to career ladders. You know, you can just look at the Paraprofessional Healthcare Institute. There's a whole list of things that you can do. There's instruments that enable to evaluate burnout. It's absolutely critical because then you can target your intervention on an individual basis with staff members. You can take them to retreats. You can work with them to strengthen relationship with all other departments, with family members, and not to require them or enable them to do the double shift, the 3 shifts, and to be completely exhausted. Many have health issues. Many are single mothers, barely finishing the month financially. They have a lot of health and injuries already. So I think that this should be a very thoughtful, comprehensive approach. Many delicate staff don't have a health insurance. There's organizations such as Paraprofessional Health Institute that are advocating for improved working conditions. So there's a lot of things that can be done.
Thank you very much. Do we have anyone on the phone with a question, operator?
We currently don't have any questions on the phone.
Okay, let me just see. There might be one more here. Here, this is kind of I don't know that we have time for this, but just read it one more real quick in the interest of time. We're having negative experience of being in a rural area in Minnesota and having aggressive behaviors occur, resulting in transfer to local hospital. Unfortunately, there was not enough available psychiatric support, and residents were quickly sent back to us. This sounds familiar. Where did it go? We found the waiting list to transfer to the psych facility that could do the needed medication change and behavior support was about 4 months. So I guess that's an FYI. So it kind of leaves you in a pickle.
Yeah, so I think that this is a systemic issue, and as part of the presentation that I skipped those series of slides. There's a lot of systemic issues that occur outside the long-term care home. So as a society, on a federal level and on a state level, we need to create those settings that enable to a small-scale care homes that that there's a higher level of staffing and higher level of programming that is tailored to these individuals that long-term care homes, traditional ones, find difficult to care for. But this requires advocacy. Some states do a better job than others, so we really need to continue and advocate for those settings. But families really find themselves in a very difficult situation across the country. We hear about it all the time.
Okay, so unfortunately, in the interest of time, there's a lot of questions here. You do have Dr. Caspi's email address, and please feel free to contact him if you have any questions. He'd be glad to address those. On this slide, we also have the contacts for the lead people you can contact if you're from one of the states that's part of the Lake Superior Quality Innovation Network. Otherwise, feel free to contact us even if you're not from our state, or feel free to contact whoever is leading the National Nursing Home Quality Care Collaborative in your state. Dr. Caspi?
I just want to say one quick thing. I'm focusing on this public health problem for over 8 years, and while we should continue to advocate for changing staffing and training and culture and everything, of course, I am trying to find producers and funders to do a documentary film on this public health problem. There's films and campaigns on bullying among kids and youth and violence among youth. I haven't seen a full-length documentary on these behaviors in order to raise awareness in the public and touch the conscience of the public, and maybe that will help also with legislation and implementation of the practices that we want to see in place. So if any of you hear about a talented producer or somebody who's willing to work with me to fund this project, I'll be very happy to hear about it. I am in contact with family members that are willing to interview for this film across North America and other countries. So thank you for joining today, and I hope you found it useful, and please feel free to continue the dialogue with the email later on.
Thank you again. This is really great information. So to receive education credits for this webinar, you will need to complete the evaluation. As you close out of the webinar, the evaluation will come up for you to complete. There's also in your handouts, as well as in the chat, there is a link to the evaluation, and once you fill that out, you will get a certificate. So that concludes the webinar. Everyone have a great rest of your day, and we look forward to talking again about some very important issues in long-term care. Thank you.
Thank you, Christy. Thank you, Kathy.